All right, hello everybody. Thank you all so much for being here for our second regional meeting of our toolkit for evaluation, assessment, and monitoring for our adult community services and support programs. I'm Andy Sarkin, and uh, I'm going to start off after just saying again that it's just so important to have you all here, and we really hope that you'll get a lot out of today. That'll be really engaging and really inspiring, but you'll have something to bring out of this. And we couldn't do it without you being here. It's such so important to our success that you all showed up, and thank you all on behalf of us and MHSOAC. And for now, I'm going to turn it over to Fred Molitor from MHSOAC to greet you, and then I'll come back.
Thanks, Andy. Welcome, everyone. My name is Fred Molitor. I'm the Director of Research and Evaluation at the MHSOAC. So this project is extremely exciting. This is how projects should work, is that we have, as we've advertised in some of the materials, two parts of this project. We work with Andy and his team to put together the evaluation system or to support their work in putting together the tracking, monitoring, and evaluation system that's going to be presented today. And then Brian Sala, who's here today, our Deputy Director of Programs and Evaluation, and I said, well, we should bring this to the next step, and that is it's one thing to have the system, but it's another to have a toolkit that will allow counties and providers to assess their readiness for it, to what degree that they need to prepare in certain ways to adopt the system, and then, of course, the system itself, its uses and its advantages, which you'll hear about today. And then we decided to, which of course is what today's all about, is to bring together, when the toolkit is still in draft form, groups of individuals who will be involved both in the potential decision making to adopt the system and to potentially use it, to have folks brought together in San Diego, which we did a couple weeks ago, and of course today here in Sacramento, to get your feedback, your impressions, and possibly make changes to the toolkit, and really to promote it, because we were convinced, and it's certainly the impression that we got from the attendees in San Diego, that this has potential to be of great value, both in terms of improving services for consumers, making data-driven decisions, and then also making efforts easier for staff who are providing those services. So again, it's very exciting, one because we can adopt rather than while the process is still going before the tool gets finalized, feedback from individuals such as you today. But it's also a very exciting system because it's not a take it or leave it system. As you'll hear about today from Andy and his team, it really provides a number of different instruments and features that individuals can pick and choose from that will be very helpful, that we think will be very helpful in the work that you do. It's available to the counties for free. So again, the MHSOAC is funding the system and the toolkit, but it will be available free to counties to use. And as I've already said too, we really think both in the office and from the feedback that we've got, that this will be of great value to the services that are provided at the county level. So I wanted to take this opportunity to talk a little bit about the research and evaluation unit that I oversee at the OAC, and then also some of the projects that we're working on. So we've really increased staff within a research and evaluation unit, and I'm really excited about that. One of our new senior researchers is Pu Peng, who's here today, and she oversees our data analyses and management. So she's working with one of our contractors, who many of you may know, MH Data, to learn about the CSI and DCR data, and really then use those in new ways. So we have, through our criminal justice and mental health project, policy project, we have the opportunity to link the CSI data with DOJ data and really answer some basic but extremely important questions in terms of the distribution of involvement with mental health clients and justice system, maybe dispel some of the myths or some of the misperceptions that the public has in terms of mental health clients or consumers and their involvement in the criminal justice system. And then we also are working with the Employment Development Department, because unemployment is one of the 7 outcomes of the MHSA, and being able to link EDD data and mental health data to look at overall in terms of employment and wages across mental health clients, and then potential changes over time in terms of receipt of services and then ongoing services. And then we also have a newer researcher, Kayla Landry, who's here today. She's overseeing our schools and mental health policy project. So our 2 policy projects that we're really working on now on a day-to-day basis is criminal justice and mental health, and then the newer one is schools and mental health that Kai's overseeing. And these are the policy projects, as some of you know, that we have public engagement activities, we have site visits, we have public hearings, we have subcommittee work group meetings open to the public, because both criminal justice and the schools project, we are by no means the experts. We are relying on experts, whether it be consumers, family members of consumers, researchers, providers, to really help us frame the problem, what potential solutions there are, and then the implementation of those solutions that the commissioners may be able to bring at a statewide level. So the Schools and Mental Health Project the focus is trying to identify, this project is overseen, the subcommittee chair is Commissioner Gordon, Dave Gordon, Sacramento County Office of Education Superintendent. He's the one that's really spearheading this project, and his focus is really identifying children within the school at a much earlier age than is often the case for the need for mental health services. And so these would be as young as preschool age children who school administrators, teachers, and staff may identify early on that there's a need there, but they don't really know what to do, or they really don't know how to address that. So it would be providing an opportunity both for the identification of younger students earlier than is often the case, and then identifying those services, identifying those with students that need services, and then providing those appropriate services. And the main goal is to try to divert children as early as possible on the trajectory to getting in special education because of emotional or disturbance, emotional behavior problems. Because as Dave Gordon will say, is that the special ed is not the solution for those types of students. And a lot of times that those students end up actually doing worse in special ed than otherwise. So it's really to try to prevent that, and most importantly, of course, providing appropriate services for those students. And then also newer research assistant is Kayla Landry. So she, as many of you know from corresponding with her or meeting her today, she's really helped a lot in terms of putting today's event together. We also have, just real quick, we're working on our triage, getting ready for the next cycle for triage funding, and we're going to implement some changes, or we hope to, in terms of those services, specifically the evaluation. We're thinking about having a more focused evaluation, limited outcomes, but the most important thing, I think, is that we're really going to provide the opportunity to bring, as is currently the case, the project directors together from the counties, from the triage triage programs, but also the evaluators, both to learn from each other, and then so that we can learn from them in terms of what's working, not working, and so that we can address that appropriately. We also have a pilot study looking at duration of untreated mental illness. We partnered with a researcher from UC Davis to help us figure out, by the data that she's collecting, what are the best ways that you can assess duration of untreated mental illness, which some of you may know is the outcome for PEI, so that we can use the information that she's gathered from collecting data on early psychosis programs, and then make recommendations in terms of how we can then provide guidance and education and support in terms of making the data collection at the county level possibly less burdensome, but just as important, make the data that's collected of highest quality, so both at a county level and at a state level, we can really see to what degree that is an outcome shows success for the services that provided. So also today here we have a number of OAC staff who are not in the research and evaluation unit that I wanted to mention. Some of you may know them or have talked to them by phone. So we have Greg Tate, who's here in the background. We have Sydney Armendariz back there. Kim Johnson is here, and then Wendy DeSormo. Very good. Matt Lieberman's over here, and Corinne Sugaswara. Thank you. And then I also mentioned Brian. That's everyone who's here right in the office. Okay, very good. Well, thank you again for coming. It's going to be a very exciting day. I'll turn it back over to Andy.
Thank you, Fred. And I'm just going to spend a couple minutes putting this whole toolkit thing into context in terms of even what are we talking about here with the toolkit? Why am I so excited about it? And then we'll talk a little bit about the agenda for the day, introduce our team, and then I'm going to have Francis give you a brief introduction, a little more about the pieces of the toolkit before lunch. So, sorry, 1 second here. There it goes. Sorry, 1 second. Okay. So, many of you have already seen a lot of things like the toolkit that we'll be talking about today, because so much of it came from the great work that you guys have already been doing for years. We didn't just kind of pull this out of nowhere. This came from us studying some of the best practices that people here in the room and the counties have been doing. And hopefully, even though there may be some things you've already seen, we think everybody will hear some things today of new ways of using measures and making what you're already doing more meaningful. And you're also making a huge contribution in helping us nail down the toolkit to make it as useful as possible to folks like you, because of course we want to get the best value for it, for the state, and make it be something that's useful to a wide audience. So I wanted to give a couple examples of what we might do with such a toolkit. So of course, when I say toolkit, I'm talking about a kind of set of measures and procedures and instructions and all the things around what you might need to do to have a self-contained system for doing evaluation. And so some counties or programs could adopt the toolkit as a whole, but also you might find today that there's certain single measures within the toolkit that would be ideal for your county or program, or ways that we're reporting things. Or we'll even talk about some ways to best use and implement a new data system, even if it wasn't the toolkit. If you were thinking about implementing something else, you'll learn some things about that today. You see on the table that we have copies of the toolkit there available for you to look at during the day. We only had a few copies per table, and a few got stolen in San Diego. So please, folks, don't take those away, because also they're a earlier version. You're going to help us create the final version, and then we'll go ahead and distribute that. And there's a couple of black and whites, I think, on each table, and one color, I believe. So we have a very full day of activities here. Early in the day, we're going to tell you about the toolkit, hopefully excite you about what you can do with it. And then for the second half of our activities, we're going to be getting feedback from you, first in a larger group, and then through discussions that we'll have at the table, some breakout discussions. And so during the presentations, we thought we would hold questions and discussion, and so there's cards on your table to please go ahead and write down We do have cards on the table, yes. uh, so go ahead and write down your comments and questions on those cards. We'll be coming around and picking those up. But then also after our presentation, we will have an open forum discussion here. And certainly feel free to still mention things you may have written on a card during our open discussion. We've recruited one person per table to help us with running those breakout groups in the afternoon. And so thank you so much to the folks who have agreed to help us with that. And these are really, I want to let everyone know, are folks just like you who have just stepped up and been willing to kind of be the, as we know in these meetings, we often nominate a note taker at the table. Well, we've kind of pre-nominated someone, but they're going to be someone who's here at the meeting to learn about it today, just like you are, and won't have all the answers to your questions and such, but will be a great person to help organize our discussion and help us make the most of your information. And then we'll, at the end of our breakout sessions, we'll have those people share with us a few of the main points that were discussed. Couple quick housekeeping things I think we have. For parking validation, I think many of you already have that taken care of. For those of you who don't, you will get a white ticket from Kayla and go ahead and put that in the machine when you leave, along with the parking ticket that you have, and that should take care of your parking fine. The meeting will be recorded, and our plan here will be to have a very short welcome and introduction that, as you can see, we're already, most of our time, I've already used up much of our time on that. So I'm going to turn over to Francis here in a moment. And then we're going to dive right into lunch. I know it seems pretty quick, but I know many of you traveled, and and I think that would be a great time for folks to get to know the other folks at your table and to start a conversation about what you're interested in and what you'd like to get out of today, and maybe take a look at some of those copies of the toolkit that are on the table. And then we'll start our presentations at around 12:30. But you can still relax and keep eating your lunch as we start to tell you more about the toolkit. Then we'll have a break at 2:30 and organize into our breakout groups, where we may reorganize tables just a little bit, depending on if any folks need to leave early or anything. And we'll have our wrap up and final comments at the end of the day. Quick introduction of our team. I'm Andy Sarkin. We have our project manager here, Francis Reyes. Gina is inside now. Gina Beal, who many of you met at registration. Edith Wilson is here. And Lucinda Clinica. And you'll be hearing from all of them talking about parts of the toolkit that they especially worked on. And we also, as Fred said, there's a bunch of our partners from OAC here. These are a few of the folks we've been working most closely with. Fred and Kayla and Mary Joyce isn't here with us today. So with that, I'm going to turn it over to Francis to give you a little bit of introduction.
Andy. So as Andy mentioned, I'm going to give you a really quick introduction, and then we're going to go into lunch in a few minutes. So I'm just going to talk a little bit more about what the toolkit is, why it was developed, how you can use it, and who should be using it. So what exactly is the Toolkit for Evaluation, Assessment, and Measurement? Basically, it's a set of resources and information that will support California counties in taking stock of their resources and tools to figure out if they are ready to implement a data collection and reporting system. It will help counties and providers use measures and implement data collection successfully, and also help them provide training to the staff people who will be using the measure. Include some tools that will help programs process the data that's collected and create and use evaluation reports. And finally, the toolkit will include some guidance on how the resources can be customized so it can suit a county's individual needs. Right, so these are a few of the toolkit components that we will show you today. So there will be some introductory materials explaining the background, purpose, the intended audience of the toolkit, the importance of data collection and evaluation, processes involved in developing the toolkit, and guidance on toolkit implementation for counties and providers. There will be a feasibility checklist with items that will help encourage counties and programs to consider their organizational characteristics, such as the resources they have available, staff training and assessment, evaluation culture, in order to assess the readiness for adoption of a data collection and evaluation system. It will include some decision support tools, such as information on measures that were selected and guidance on selecting appropriate data elements based on program characteristics, guidance on integrating a data collection and reporting system into existing data collection record systems, and the toolkit will include a detailed map for the processes for data integration. There will also be some data entry and reporting tools that programs can use in Excel. Oh, sorry about that. All right, is that better? All right. So going back to this, like I said, there will be some data entry and reporting tools that programs can use in Excel. Will include some data entry templates and some really nice automated dashboards. There will be training materials to help people learn how to use all of the tools in the toolkit. And finally, there will be some supplemental documents, such as a data use agreement template for negotiating the sharing of data, and also recommendations for how to launch and promote use of the toolkit. Right, so why was the toolkit developed? Well, OAC wanted to provide support to counties to evaluate data in meaningful ways without adding requirements. Additionally, the toolkit was created to provide better resources to help counties collect, process, and analyze data to inform service and resource planning. Also, the toolkit was developed to help clinicians make use of the data that they collect in order to best help the people that they serve. And also, the toolkit will help give clients and their families and other supporters a stronger voice in client care. So these are just a few things that the toolkit will hope to address. Like, how can the toolkit be used? So you can take the entire toolkit and all of the pieces of it and implement everything as prescribed, but you can also take certain elements of the tools and customize that so it suits your needs for your county and local requirements. You can take certain tools and just decide to implement those. Right, so these are a few of the individuals who we think would benefit from using the toolkit. So that includes clinical or medical directors, program directors and managers, mental health researchers, program evaluation and quality improvement analysts, county or program informatics coordinators, and behavioral health care providers. All right, so that was my quick overview. I believe we should be having lunch soon, and we're going to have a short break, and we'll come back at 12:30 to resume our presentation and talk a little bit more about the history of the toolkit and how it was developed a little more.
Francis. And yes, I think lunch is coming out in a few minutes here. And so while we're waiting a moment, as you saw, my notes were a little funny there at the beginning. So I wanted to mention one other really important thing, how this fits into MHSOAC's kind of greater strategy to support the counties. And so I want to make sure that's clear to everyone, this is not related to any new requirements or anything new that folks are being asked to do, but rather this is OAC really trying to help us all by providing optional to use free tools that will empower everyone in the counties and programs to be able to do evaluation on their own and to choose what type of evaluation and what evaluation questions best fit them and their resources rather than having it dictated to you. So I just wanted to leave you with that point and enjoy your lunch. All right, we're going to get started again here. Again, feel free to keep enjoying your desserts and coffee as we get going again. I'm going to be starting off now with some information about the earlier project that we did, that the toolkit came out of. And of course, it's critical to be thinking about where this toolkit came from and how it came about. So, of course, I don't need to remind you folks that there's a lot of value in doing evaluation. There are conversations at our table about it, and we hear about it from all kinds of places these days. The importance of having numbers, of having evidence of the effectiveness of our program. And so reasons for that, of course, are we want to always be doing continuous program improvement, identifying training and technical assistance needs, testing program changes or new programs, which especially with our MHSA programs, they're all new in a sense, many of them, and identifying client groups that need attention when we have a moving landscape beneath us in terms of the needs of the people that we serve and the funding streams and other things going on that sometimes aren't always under our control. It's important to have accountability to stakeholders to show that we're effectively using the resources that we're given, and it's critical for securing future funding. And when I was thinking about this presentation in light of our new, what we've heard about the budget lately, the federal budget, of course, nothing's been decided there, but why are they saying some programs could be cut? Because there's not evidence that they're accomplishing their goals besides anecdotal and such. So we know that our programs, I think, are effective in doing good things, but it's really important to have the data to back that up. And this also helps our individual clients, though. This isn't just a burden. And that's why it's really important that the evaluation toolkit that we're showing you today is not a black hole of data. It's not something that clinicians and the clients that they serve put data into, and maybe we'll learn something when somebody does something with it. That really, it's about making sure that what the clinicians are collecting is useful on a daily basis to help them with the people they serve. And it's really important that, of course, for the buy-in to have our staff. I'm a clinical psychologist myself by training, so I know what it's like when people are asked to do more paperwork or to do additional work. And, oh, we can fit it in. It's just one more form. I know that that's easier said than done. And so again, hopefully what I'm trying to show you here today, you'll agree that the value is greater than the burden, which is how we justify that we do this. It's going to track individual progress and help with treatment planning for our clients, promotes an integrated recovery orientation, and gets us out of a mindset of thinking just about illnesses or symptoms or classifications such as that, and facilitates recovery and communication between the people who are receiving services and those who are serving them, and also between service providers in an integrated system that I like to say that some of these toolkit elements, if we got many of us on board using them, it provides a common language for us. And so if we're using similar measures, then many people in the room know what I mean when I say, well, many people in our population have a milestones of recovery scale score of around 5. I see some people nodding. I know what you mean by milestones of recovery scale. Or if I said they have a Jones index of 5, you'd be like, oh, Jones index. And so having a common language among clinicians when we're working together to help people is really important. It can, in terms of the clinical utility, helps us better to understand the people we're serving, helps to comprehensively assess their needs, again, aids in treatment planning and concrete goal setting, as opposed to let's just get better. We can say, what's our goal of what point we'd like to reach, and then track our progress reaching it together with our clients. And again, in that same sense, it helps us to assess that recovery progress and outcomes, identify critical indicators, identify strengths that can aid in recovery, And hopefully you'll see that these instruments are all have a basis in strengths and enhances the therapeutic dialogue in those ways that I mentioned. So to tell you a little bit about our earlier project, briefly here, because I want to get to what you guys are here to talk about the toolkit, and we're here to get feedback from you about it. But to put it into context, we, between May 2014 and June 2016, completed a project that was called the CSS Tracking, Monitoring, and Evaluation Project, and that was meant to develop and pilot a standardized data collection system for adults receiving non-FSP CSS services that would allow for evaluation of clients and the quality and appropriateness of services, and to be integrated into other electronic health records or data collection reporting systems, such as many of us have heard of EDHS or Avatar, or you may have other ones that you use, and that's another really important quality of everything we're talking about today, that you don't have to use a certain system to use what we're presenting today. It is meant to work with your data collection choices. And our goal was to create policy and practice recommendations for how to improve upon the way that we currently evaluate and judge our CSS programs. So the main questions were, what statewide methods should be employed to ensure proper tracking, monitoring, and evaluation of these programs? What policies, practices, systems, and infrastructure should be created or modified for folks to better be able to track, monitor, and evaluate programs? And how can we better use that information? So we don't want to stop at just collecting good information. We need to make sure that it's being used effectively to not only inform policy, but inform making sure that we meet the individual needs of hopefully as many clients that we can, if not every single one. So we went about our work. We reviewed a lot of stuff. Samples of what we looked at include, of course, our Mental Health Services Act itself and the goals, and other laws that are still relevant, very much, Bronson-McCorkdale, for example. We looked at MHS-OAC and DHCS goals that we gathered by meeting with their staff, and looked at the National Behavioral Healthcare Quality Framework, relevant published work on measuring outcomes, and results of other similar projects. It was a very important part of the work we did, that we know that when people look at a project like this, they say, wait a minute, haven't people done some similar things like this that we've heard of in the state over the years? And so we made sure that we looked at what else had been done, made sure we made the best use of that information, and not just reinvented the wheel. Our stakeholders in the Evaluation Advisory Group provided input on which measures to implement and what procedures to use to make sure that it fit with people's workflow. And so we made sure, of course, we had a variety of folks that I'll mention in a moment. We reviewed current systems such as CSI, DCR, and electronic health records that you use in different counties, and evaluated and compared validated health measures, because that was an important part of our contract. Many times we measure things, our outcomes, that seem to make sense on the face of them, but back to that thing I was talking about with evidence, to really have solid evidence, we'd like to use measures that have been proven to effectively measure what we're trying to show our improvement in, the program goals. And so sometimes we still did use things such as that are in the DCR, which sound fine, but haven't really been shown to always be validated. But then, of course, because not everything we needed to measure could be found in a validated measure. And we went through a big process of comparing the different measures, where we had stakeholders, including for the self-report, of course, clients who actually get the services, asking them, what are meaningful outcomes to you, and which of these questionnaires resonates with, that's what I think of when I think about getting better. And we also used a more objective assessment instrument quality checklist that come to these measures, where showing you today, our goals were to maximize usefulness to staff, usefulness to people getting services, validity for measuring the goals and outcomes that are relevant to our programs, and of course, in line with the MHSA law, and paying attention to cultural competence and sensitivity. We wanted to minimize burden to staff, burden to people getting services, and make sure that none of these measures incurred any extra cost for the program, such as any fees per use or anything like that. So we reviewed the available measures for those things we're talking about, our relevance to goals, our clinical utility for the clinicians to use it on a daily basis, the validity, cultural competence, or often I like to say cultural sensitivity, and cost, copyright, and translation issues. We developed some questions and had meetings with all those different sorts of stakeholders, including program directors, cores and administrators at the county level, local experts and academics, staff who deliver services, and the people getting services. And our contributing stakeholders, thank you to folks here in the room who may be parts of these organizations or helped us as part of our evaluation advisory group. We have the Mental Health Services Oversight and Accountability Commission, California Department of Healthcare Services, Racial and Ethnic Mental Health Disparities Coalition, the California Mental Health Planning Council, and those different groups, our county administrators, supervisors, clinicians and staff, subject matter experts. We were very lucky to have some of our well-known names in the history of California mental health, like Bruce Bronson and Rusty Felix involved, and a lot of involvement from people with lived experience and their families. And we formed an evaluation advisory group that had some representation from all of those folks. So just a couple more slides here. I want to just give you a sample of what we did there, and then how it goes into, how that fits in with our toolkit, which was not a deliverable of this project I'm describing, of course. We were able to assemble all this information from the stakeholders, current legislation, mental health agencies, the data collection systems, and reviews of validated instruments and outcome measures. We developed a system and deployed it. And several counties that actually tried and collected these measures, and we very much appreciate the participation of them, and they gave us feedback. With the folks who tried it out, we then had focus groups and surveys and other ways to gather information from the staff to improve the system that we had implemented. And we tried to fill in some gaps based on what we had learned from the stakeholders, such as the need for a family or friend completed measure and a strength-based self-report. And just a sample of a few of our recommendations that we made. Actually, there were dozens in about 5 or 6 categories and many recommendations. Some of them included things about the clinical measures that we should use, such as the use of validated recovery-oriented measures, having something completed by a family member or close supporter, using client-completed measures. We had a lot of recommendations about a data collection system. And this, of course, was talking about more on a statewide scale, what a data collection systems might look like that could replace some of these other things that that some of you know of as CSI, DCR, or other acronyms of data collection systems. Don't worry if you don't know exactly those ones. And we made sure that we talked about how to integrate things that people need to have not another system to log into. And so that's hopefully not what we're bringing to you today, though some people could use this as a standalone system, but also this is a way to maximize use of other data collection systems to better use information, some of which you're already collecting. And we made a lot of reporting recommendations based on our stakeholders of what the most useful way to present information, what ways they wanted to see information, and how to provide training for them to use the data in meaningful ways. So, just a couple words on the transition, and I'm going to turn it over to Francis here about the transition to this new project. So as I was bragging a bit there in terms of being really proud of what we accomplished in that first project, but we know things don't move really fast at such a huge level. And that's not, I don't think, the fault of California or agencies in California, but it's just hard to move big ships. put them in a different direction. So while we made all these recommendations that we still think are very useful for the state in terms of planning how we might go forward with larger systems top down, we discovered so many great things through this project. We wanted to make them available immediately. And so that's the purpose of the toolkit, is to take what we learned in this project I've been describing and make it so that in the months to come, not years to come, folks here in the room could pick and choose pieces that are most useful to them and incorporate them into their work. Hopefully add value to what you're already doing. So with that, I'm going to turn it over to Francis to tell you about this.
All right, so as Andy mentioned, the goal of the current phase, we're in phase 2 of the toolkit, is to package up everything that we learned and that we developed during phase 1. Right? And I'm going to go a little bit more into the details of the purpose of the toolkit. And I already may have mentioned a few of these during my first part of the presentation. So one of our goals was to be able to provide a set of resources that would help provide guidance on how to prepare for implementing a tracking, monitoring, and data collection system. So we have some nice materials that will help counties assess what they need, what resources they need.
Oh my God.
Report on what guidance due to support to counties and technical assistance to those counties who wish to adopt the system. Another purpose of it was to help provide mechanisms for negotiating and sharing tracking, monitoring, and evaluation data. And finally, we wanted to provide some tools that can help play a role in oversight in assessment and treatment. How did we develop the toolkit? These are the steps we took to get to where we are today with our draft toolkit. So as we mentioned before, we reviewed the results of phase 1 and developed a project plan and timeline based on what we found. We selected a group of some subject matter experts and key stakeholders, and we formed a stakeholder group called our Toolkit Evaluation Advisory Group with a few of these folks, and we also conducted some expert interviews for those specific areas we really wanted to hone in on. So using all of this information from stakeholders and our previous project, we developed the draft toolkit, which we're presenting to you all today. And we're hoping to get some really great input on the toolkit so we can further develop it and create a final draft. Is our project timeline. As you can see, we started working on the toolkit back in October. We submitted our first draft of the toolkit last month. And obviously it's March, so we are conducting these regional meetings. We had one in San Diego, and we're going to use all of that feedback, like I said, to develop the final toolkit, which will be completed in July this year. Right, so I just want to talk a little bit more about our Toolkit Evaluation Advisory Group. And this was a huge part of developing all the materials in our toolkit. So, of implementing the Evaluation Advisory Group, we wanted to review, have folks review toolkit materials to maximize external credibility, ensure that the methodological integrity of evaluation was kept. We also wanted to make sure that all stakeholder viewpoints were addressed. We wanted to make sure that toolkit meets the needs of staff and clients. So we want to make sure all of that is addressed, as I said. We also want to talk about strategies to toolkit for all stakeholders. And finally, we wanted to seek some or get some feedback from our evaluation advisory group on what we can do to promote the use of the tool and make it as useful as possible to folks who. So these are some of our EAG members. I know a few of you are here today. I'm very happy to have you all here. All right, so now we're going to talk a little bit more about each of the different components of the toolkit. Give you a preview of everything included. These are some of the features of our toolkit that we will be presenting to you today. All right, so we broke down the toolkit into these 5 main sections: assessment measures, integration into existing data collection systems, data entry and reporting, preparation and promotional materials. And now I'm going to hand things back over to Andy, who will talk to you a little bit more about assessment measures.
Thank you, Francis. So the toolkit includes a set of questionnaires that really is much of the core of a tool of many of these toolkits that you may see that we need, and also but then we've also added a lot of supplemental materials for tracking, monitoring, and evaluating the client outcomes, such as decision tools to aid in the selection of measures and how to implement them, and training materials with guidance on the implementation of the new measures. The measures that were chosen through this process, of course, we would love to have every measure that folks might want to use included in the toolkit, but then imagine how big that would be to use, how unwieldy, and so hopefully you can forgive us if there's something, if there's additional measures, and that's why it's great about it being modular and what we're going to hear from you folks about today. So we still want to hear about what things are missing, and even if we don't add them right now, the things that folks want to see added in the future. But our kind of limited set of measures that are currently included in the toolkit, I'm going to go over briefly now. This slide is just kind of a summary of all of them, but I'm going to go through. We have a clinician. I should mention, of course, that in terms of just the overall, that there's an intake assessment, and then there's a clinician assessment that gets done at intake and periodically, like every 6 months, depending on what you think is appropriate. A self-assessment completed by the client, a family friend measure completed by a family or friend or other supporter, and the consumer perception survey, some of you know as the MISIP, which we are already using, but we want to maximize the use we get out of that data that we're collecting. So the clinician assessment, some of you are familiar with some of these measures, includes the illness management and recovery scales, progress towards goals, housing level and stability, employment, frequency of critical events such as hospitalization, and demographics, which of course we don't want to have you redundantly put in our system. So if you're already putting demographics somewhere, we're trying to give ways to move that into our system to reduce that redundancy. And we did design our demographics to adhere to the MHSA regulations for innovation and PEI, which this slide always reminds me to mention that we are focused on CSS programs and name this toolkit for CSS programs, but there are definitely elements of this that would be very useful to some PEI programs. And of course, we know for our innovation programs, many of those resemble a CSS type program, but they're a new innovative sort of program. And so many of these tools, this toolkit itself is actually very nice for innovation programs also. And I skipped over milestones and recovery scale somehow. Quick look at these scales, which these are all in the documents on the table. So you have the illness management and recovery scales, which are 15 items with anchored responses. And my anchored responses are, I know you can't read this too well, but for time and stuff how much time does the person spend in structured roles? I think that's a good example of where they, first of all, define well, what do we mean by structured roles, as opposed to just saying structured roles. And then instead of saying, oh, a little or a lot, they give specific amounts of time, 2 hours or less per week, 3 to 5 hours, 6 to 15 hours. And so that measure is already used in multiple counties, and folks have found it very useful and easy to complete. And it gets reduced, and it produces 3 scales. So from these 15 items, we can also get 3 scale scores for how well the person's illness and symptoms are being managed. But then, of course, importantly, how much they are participating in recovery-oriented behaviors and self-management. And it has a substance abuse scale, which, of course, is an important feature for any such measurement system. And we have to have, usually in our populations, we want to have some reflection of substance abuse. As I said, it's given at intake, follow-up, such as every 6 months, depending on what your decision is, how often it should be. We give guidance, and at discharge. We have the milestones of recovery scale. Many folks are familiar with that being, and again, that's where I like this idea of that if we all use some common measures, there's such great things we can do in terms of being able to look at the effectiveness of our programs across different programs and across different counties and different age groups and all the things we'd like to be able to compare. Well, we can't compare if we're looking at them through different lenses. And so this milestones of recovery scale, that's just the one item with the 8 levels that many folks are familiar with. We have a few goals items because this was seen as very important to our stakeholders. And we have 7 items, but of course, you guys get to choose how you want to use the toolkit. You may not want to use all 7 items. These are completed at follow-up and discharge. And these are the 8 areas that our stakeholders thought were most important in terms of trying to limit burden. Of course, there's more things we might want to know about. And so we have employment, housing, education, mental health, substance use, family reunification, social health, and physical health. And the clinician basically, in their opinion, states how much the person has made progress towards their treatment goal, or perhaps maybe they don't have a treatment goal in that area. Then we have a self-assessment. And I know I keep saying this. This is another piece of the toolkit that someone may say, oh, I don't want to use the whole toolkit, but that one piece I like. We'd like to bring that in with what we're already doing. So we've created the CHAMPS, Combined Health Assessment for Mental, Physical, Social, Substance, and Strength. It can be as short as 1 page, depending on how you use it. It includes the promised global health items, which are a part of the National Institutes of Health Promise. So many folks may not have heard of that, but it's a system of measuring our emotional distress, plus a lot of just general things like quality of life and our physical health, all in a very compact package. So there's a lot of bang for the buck there in terms of what we're able to look at. And it screens and alerts for suicidality and relapse, recovery oriented, and has several strength items, has substance abuse questions, provides this quality of life indicator, and that relates to that this self-report measure is special in that it can be used to do cost effectiveness in a way that we don't often do. And some of our cost effectiveness folks now working at the state level have expressed a great interest in being able to look at it this way, because so many times when we do cost effectiveness, for example, for an FSP program, full service partnership, we say, okay, how much did we keep them out of jail and out of the hospital? And that's how we're going to justify our cost, because we save this much money from jail and hospitalization. And that's good. Can't say that's not a worthy way to look at it, but what we're able to do with this scale here is we're able to ask how much health do we buy? And through a variety of research that has been done at the national level by a lot of experts in cost and health, we have been able to have this comparison between programs. So it's hard to put a dollar amount on how much a certain amount of health you buy is worth. You certainly can use it to compare programs. You could say, I can buy more health per dollar with this type of program issues of comparing apples and oranges we have to be careful of. And these are the domains that are on that self-report measure: strength, mental health, physical health, social health, quality of life, symptoms, suicidality, and so on. And now I'm going to mention the family and friend version of the illness management and recovery scale, which as a part of this last was developed as a part of our earlier project in conjunction with the authors and creators of the illness management and recovery therapy system. So illness management and recovery, we often think of it as a measure, some of us who use it, but it's actually an evidence-based treatment system that comes from SAMHSA. And the measure is a part of it that we use here in our toolkit. But some folks out there actually using this illness management and recovery system, and even if you aren't, we found these items that come from it to be ideal. And so we developed a family or friend version that is a lot like the clinician version, but now, of course, we have a critical new person in the mix to give us information that may be missed by the clinician in the short time they're with the client, and the client may not be fully forthcoming about. Or the client may not have the insight at that moment to realize exactly where they're at. And so that has items that are just like the clinician version. Asking about the person's knowledge about their illness, time and structured roles, how much the family or friend feels the person's impaired by their functioning. So now we have presented this handful of measures and said, well, you can use one or two or all. How do we decide that? Well, we hopefully have helped you there with these outcome measures decision tools. The purpose of this is to help you determine which ones best fit your needs and your program characteristics. And this is meant to be used by teams or individuals, usually from the county or program leadership, who are making the decisions about what assessments are going to be done. And I would highly recommend having frontline clinicians and folks with lived experience, representatives in your county, be a part of the discussion. So now I'm going to flash up a few slides that you're not going to be able to read. It's just to give you an idea. So I'm just going to go through them quickly. So intake and discharge. So you see we have a sort of flow chart. And so we have a flow chart where that helps us make the decision of what to use. And so this is for the client and family friend self-reports, and this is for the clinician assessment. So again, don't worry that you can't read that, because I'm going to show you what it looks like in action. So here's an example based on part of the clinician assessment. So here I am deciding, okay, for our clinician assessment, what are we going to use? Well, first, I need to ask, are program staff available to complete assessments? Because if we're a clubhouse, nobody's going to be completing these measures and such. So are there staff available to complete assessments? If yes, then now we're also going to ask, are mental health staff available? Because there's certain measures here that could be completed by anyone working. Could be by someone, lots of different sorts of staff members could complete. But certain measures, such as the MORES, should be completed by someone with some mental health training. And in our recommendations, we do recommend a very low bar for what we call mental health training. It could be just any sort of peer certificate, any sort of formal training in mental health, where the person can reasonably expect it to understand the terminology and such that are on these. The answer is yes. So now we're going to go to, that means we can use the IMR, the MORE, the goals items we talked about, and the key outcomes of housing and employment and such. And it doesn't mean we're going to use all those. We're going to now go to and decide which of those to use. But if we had a no for the mental health staff, well, now we're just going to go to key outcomes, because IMR, MORES, and goals are not in our wheelhouse. If we don't have staff available to complete assessments, then we're not going to have a clinician assessment. Does that mean we're done? No. I mean, now we have these other things, such as the possibility of using client assessments that are administered in a pure sort of environment like a clubhouse. So now we said above there, let's say I got a yes. So I was taken up to that very top, and it's a yes, I have mental health staff available. So now I'm going to go check out, are we doing the MORS? First of all, do we need the information that's provided by the MORS? So is the evaluation of level of recovery needed? And that's, of course, a simplification of what the MORS does. So we'd want to take a look at the MORS and say, is this right for us? If the answer is yes, we do need that. We want to be tracking that. Then we have to ask ourselves, are staff trained in the MORS, or are resources available for MORS training? Because all you MORS users know we have to have our training for the MORS to properly use that instrument. If yes, we can do the training, we're all set to use the MORS. If no, then we're not going to do the MORS. And of course, if we said back here that we don't need that information, that's again the importance of having a modular system. That we aren't saying, oh, we'll just do all these things and then use the ones that are, and then actually use the information that's useful to you. We certainly don't believe in collecting information that's not going to be used in a meaningful way to help clients and people who would be helped by our program. So that's an introduction to the measures. And now I'm going to turn it over to Gina to tell you about how we integrate this into existing data collection systems.
So that we don't get blamed for having you sit for hours on end, this next part's going to involve a little bit of calisthenics. I hope you're okay with that. In case you're wondering what data integration means, it's a fancy way for data lovers to talk about how you take data from one database and put it in another one. So not everybody here is a data lover, but we know that data helps us get funded. So with that, if I could have everybody stand up. Get a good stretch because you're going to sit back down in a second. This is also for all those data people who sit in a small closet, right? Okay, so I know we all use data in some way, shape, or form, and since I get to talk about data integration, I'm sort of curious of who we have in the room and what kind of data we're using together. So I've got a nice laundry list here of data systems that could already be used. So when I call the data system, and you may be using more than one, that you are currently using, please have a seat. Right? So we'll start at the top here with DCR, folks using DCR. You'll go ahead and have a seat. Hey, take a look around at those people. I was going to say, Fred, take a look at who's not using DCR. Okay. Anybody using EBH? EBH? EBHS? Sorry. How about Avatar? Do you have any Avatar folks? If you're using Avatar, you can raise your hand. How about M-Homes? Anybody using M-Homes around here? Awesome. Thank you. How about Clinicians Gateway? Yay, folks up front and a couple in the back. Anyone using Cerner or a version of Cerner? Great. How about Epic? Any Epic users? Any other medical record systems? Medical record system of any kind? Hospital? Okay. Dr. Samgupta, you're up here by yourself, I think. Local or county systems, so something created in Access, something that was created maybe in SQL Server. All right. And go ahead and have a seat if you're not using an electronic data collection system. Dr. Semgutu, what are you using? What in the world? Okay. Oh, see, there's quite a few. So we have a lot of different systems that we're using. And as you can see, I think just about everybody is now seated. So that informs me of one of the questions I had is how many people are not using a data collection system of some sort. So we're all using them. The key of this part of the presentation is to share with you what I feel like I've had the honor to be a part of as a prior program manager, is providing some input along with Kyle Choi, who's our informatics guru at UCSD's HSRC Research Center, who's really knows everything there is to know about informatics. And we got to collaborate in a way to make sure that there are really easy to use rules and measures and information within the toolkit that will help you adapt what you're currently using and use the really cool dashboards that Lucina is about to show you, because you're using a system already and we want to be able to have those tools and be able to show you how to easily integrate that data or get it from one place to the other without having to be an IT expert, or at least be able to have the language and a tool to share with your IT people to say, hey, here's what we need. And so I get the pleasure of being able to show you these systems. So this afternoon, I'm going to first share some variations of integration. So the integration doesn't necessarily have to be all in one. You'll see throughout the presentation this afternoon that we're often talking about taking bits and pieces. So you don't have to use your own EDC. You don't have to use what we have. You can use forms. You can use your own EDC. You can use what we have. You can use all three. And then we'll be describing some data steps for data integration and being able to export that data and what that looks like. And finally, there'll be some details for integrating the toolkit into common EDCs, several of those that I've mentioned while I had you do some calisthenics. Now, we have a flow chart. If you haven't figured out by now, we really like flow charts, and they're helpful because they give you a process and a map. As a prior program manager, I remember when people would come to me and say, hey, we've got this new grant funding. Guess what comes behind that is you're going to have to be collecting some new data. And you have to think not from how you get the data out, you have to start from the very beginning of what's needed in terms of forms and systems and all those fun things. And then how are you going to manipulate that data and how are you going to get it exported back out to tell you something meaning and useful that you not only can report to the state or the federal government, but that you can also inform your clinicians and your stakeholders and those people that are interested, and oftentimes motivate your staff. So this flow chart really just starts from the very top of first expecting that there's going to be collaboration within the organization to use the toolkit, so that you've got all the stakeholders on board. And just in a few moments, Edith is going to be talking about a feasibility checklist, which is another tool that we'll have and something that you can use to see if you're ready to implement the toolkit. And then the rest of the diagram basically just shows the different methods you might want to consider in terms of, do you go straight to implementing just the toolkit and the Excel spreadsheets and data forms that we've created for you, or are you going to be integrating that with your own system? And it kind of gives you a map of where to go. So our first variation that you can use is direct data entry. And I love the work that Lucina has done along with Justine in terms of the Excel spreadsheet you're going to see, and the really cool data entry templates that are available, that if your staff's most comfortable of doing direct data entry, then the toolkit can be used in such a way that you would enter the data into Excel, but you'll have a nice interface that makes it easy. As we all know, Excel can be a little bit wonky if you're just doing the data entry in there, and you might get data entry errors. They've done a great job in terms of being able to keep some of those errors from happening and pre-programming things within Excel. And so this is a great solution for small counties. And in Northern California, there are a couple of small counties that might want to use this. It might be a good tool for some of the rural programs as well too, that may not have the more advanced data collection systems. And it also minimizes paperwork. And so if you want to minimize the forms, you can use the toolkit itself in terms of data entry, and you'll see that shortly. The next variation gets a little bit more complicated, and it allows you to use not only your own existing EDC, but also you can enter data directly into the toolkit. And so you may have that scenario where you have a system that's built, and it may be time intensive or resource intensive to make changes to that system, and you sit down with your program and your analyst and you decide that the more cost effective way to do that would be to have some variables and fields within your current system, or you may already have some of those in there like demographics, but instead of building new things into your current system, you'll decide to use parts of the toolkit in terms of data entry. And so that's an option that you can choose from as well too. Our third system is for programs that want to use forms, and so sometimes that's easiest of having the information in a form, both that clinician report and that self-report that's filled out by the client. Those might be best used by filling out the form and then maybe having another staff person, maybe an assistant who's entering that data either into the EDC or into the toolkit. And then lastly, very similar to the third variation, is doing the forms first and then having them entered into the existing EDC. I'm sorry, in the version before too, of course, it's going to require some data migration. So you'd be migrating that data into the toolkit. And of course, this is a really great option if there's computer access limited. So maybe you might have a program where there's not a computer for every staff person, or again, it might be a rural program. Maybe it's a home visiting program where you're going to need to use the forms first, and then you'll be able to enter that into the existing EDC and or toolkit. And of course, this requires some data integration as well. Okay, so to help out with that, if you happen to be one of those people close to your copy of the toolkit, I wanted to point out a couple of sections that'll be really helpful. And that would be, first of all, on page 45, there's some great information on just a broad, overarching example and discussion about the essentials to integration. And so this isn't actually, I'm getting there in a second with this template, but just if you don't know what integration is, this is a great section to read through. And it was written in such a way that a program manager with little IT experience would be able to sort of understand. And it also provides information on how you would map the data from your own system over to the Excel spreadsheet and what that process entails, as well as some things you might have to think about as a county analyst or as a program manager about how time intensive it's going to be. Because I remember being a program manager myself, that was one of the components that I had to think about is it going to make sense for me to put this in our medical record system at the hospital, or would it be more time saving and a better use of resources, because we use Epic and that took, I mean, it's called Epic for a reason, it took forever. And so, sorry if there's any Epic folks, great system. It took forever to put it in there, and then it took forever to get it out, and in a way that we could use it. We decided that we were going to use first it was Access, and then we ended up using SQL Server for our own database because we had the resources to be able to do that. And so this is kind of a section that if you're asking those things, it gives you the nuts and bolts of what you can expect if you're going to actually map that data and if you're going to integrate it from your own system into the spreadsheet, and things you need to consider and questions you need to ask. If you get through that section, then you can go to page 49, collect $200 or more, and you'll get a fancy template, which is shown here. Now, this template was done with the fact of, again, I remember that most of the people that I was talking to as a program manager, when I made the decision to go with an Access database, still didn't know what I was talking about. And so to be able to have a template that allows you to put all the information in one place to provide to your supervisor and county analyst to let them know this is what it's going to take in order to do this is really helpful. You may decide that you don't use the toolkit at all, but this might be a really great form that you keep for future endeavors. Because it's great to have a plan in terms of data integration to be able to say, here are all the staff resources I need. If I zoom in on this a little bit, you'll see this section is thinking about things in terms of, how many people am I going to need, how many hours, who's doing what. It really gives some quantitative information to what it takes to do an integration, because it's a big task, and it's helpful to know up front and be able to share with your supervisors and those people that are also helping you make decisions of this is what it's going to take to do it. Yes, it actually is. It actually is. And what's neat, thank you for asking that question, is while the plan is not, well, actually, is it in the, where'd Francis go? Is it in the appendix? Okay. When this comes out in the electronic version, there's a PDF here, and it'll be available. And of course, remember that this will end up being a free toolkit. And so that'll be something that you can take away. And yeah, oh, is it in the appendix? Yeah, I thought it was. All of the PDFs should be in the appendix, as far as I know. And that's another thing that I love about this. It'll be really user-friendly in the sense that when we talk about a section, you don't have to go to the appendix to find it. The tool or the whatever it is right there. The measures are right there. You can click right on it. It's a great resource. And then, of course, if you've braved that plan, then your next part is you actually want to do the data mapping. So we've provided some examples here. That here shows on the left-hand side would be your own system and exactly all the fields and functions of that variable and what it needs to translate into the toolkit. So we don't have the whole spreadsheet, but we give you an example of if you're going to do a data integration, you'd want to create something like this, where you take your 10, 20, 50 variables that you're going to pull from your system and how they need to map onto the system for the toolkit, and being able to have someone do that work, be able to make sure you got all your kinks. And that's an important piece of the data integration system. And then lastly, I love this part as well. Kyle put a lot of effort into getting some information from the systems that you see listed here. And so there are some references and tools on if you have one of these systems, what process you would need to take in order to make changes to that system or request that, because that's kind of the hardest part, is where do you go first if you have one of these systems. And so he's provided some really wonderful tools on how to do that. And our next presenter is Lucinda, and she'll be sharing with you about the data entry and the reporting.
Thank you, Gina. Hello, everybody. So, yes, I will talk now a little bit more in detail about the Excel toolkit that is part of this toolkit. The toolkit contains instruments designed to aid in the processing of data captured through the assessment measures that Andy talked about. So there are some tools for data entry. There is statistical guidance and also some data dashboards. So in this presentation, I'm going to focus mostly on the data entry and data dashboards. I'm not going to talk too much about the statistical guidance, but just to let you know, this is a document that kind of describes all the statistics that we use and all the statistics that you can use for analyzing all of the elements of the assessment measures that Andy talked about. It's also part of this toolkit, and it's a great resource, especially if you're planning to integrate this toolkit or elements of it into your own system. Then you can check the statistical guidance for how to actually analyze the data. So basic functionality. We chose Excel as a kind of a tool for doing all of those great things for us, for analyzing the data and creating reports. just because Excel is very widely used. Almost everybody has Excel on their computers, and we also considered Access, but not everybody has Access, and it's a little bit more difficult to use. And most people are already familiar with Excel, so that's why we chose it, and we chose it with stakeholder input. And this Excel toolkit is it is built to support all of the assessments that Andy talked about. So Gina already described this in a lot of detail, so I'm just going to briefly summarize it and remind you again that there are different ways for data integration. There are options for manually entering data into the Excel toolkit, and you can do it directly into the spreadsheet or use some data entry forms in Excel that we created that I'm going to describe in more details in a second. You can also import the data from your existing data collection systems and import it into Excel and use Excel just for that functionality of analyzing your data and reporting. Or you can completely incorporate this whole toolkit or elements of it into your existing system and just use your existing electronic system and use this toolkit just as a kind of guidance for that. So as I said before, I'm gonna just talk in more detail now about like how actually the Excel works. So this is data entry option number 1. It is your basic Excel spreadsheet. You can so you have a column for each of the items that are on this assessment. So this example is for IMR, the Illness Management and Recovery subscale. So each column is for one of the items on the IMR, and each row is client's data. So it's very basic. This is one way to enter data. Another one, just want to mention that we also build in some data validation just to make sure that the data entry is as easy and straightforward as possible, and also to make sure that the data is as clean as possible for data analysis. So we, if somebody is trying to enter a number that is outside of the range that it should be in, then there is going to be a message pop up that will ask you to enter the correct number. And just to remind everybody again, this kind of direct data entry system is only for the smaller counties, smaller programs who will decide to choose Excel for the data entry and storage. Larger programs and counties will probably not use this, but we also wanted to make it available for the smaller programs and counties. Okay. So this is another option of manually entering data into Excel. We built an Excel form for each of the assessment tools. It looks basically like your paper form, so data entry will be very easy and straightforward and easy to do for anybody. Data entry option number 3, this is not really a data entry option, but really it's importing your data from your existing electronic data collection systems. So this will require working with your existing systems and just adding the toolkit elements that you want into those systems for data entry. But then you can export that data and import it into Excel for data analysis and data and reporting. For data analysis, we really wanted to be able to analyze data kind of like pre and post, showing change over time. So we did build it into the Excel spreadsheet, and you will be able to choose flexible date ranges. So like if you want to look at, let's say the first quarter of this fiscal year, you'll be able to choose that time frame, the date range, and then also choose the time frame for the previous assessments to see a change over time. So you can choose like 6 months before, you want to look at assessment 6 months prior, or a year prior, depending on how your program works. So for data reporting, we have data dashboards and also frequency tables. So the dashboards are more visual and kind of at a glance, gives you at a glance look at your data. And frequency tables are more detailed. And it basically shows you every single item and how many people responded on each of the items. So this is the first example of the data dashboard. This example shows you IMR. So it is the clinician rated outcome. So you have the name of the measure, kind of what grouping of the measure it is, if it's a client rated outcome, clinician rated outcome, and so on. Here it shows you the data range, like where the data comes from. Now this range is for the current assessment, and on this dashboard you can also see how it compares to the previous. But just to go back here, on top you always have a little description of what the measure is and what it's supposed to measure, because we all know that sometimes when we share reports, not everybody is familiar with all the measures, so it's important to give that little description of what the measure is and what it's supposed to measure. So this particular measure has 15 items rated on a scale from 1 to 5. So you can see here all the 15 items. I know it's a little bit hard to see. Just here. So you have all the 15 items, and then you can see the mean scores at the previous assessment and the current assessment. And also you can see the changeover times in mean scores. And then on the bottom here, you have the subscale scores and the total score. And also you can see the changeover time in those scores. Now this is fake data, so usually you probably won't see such huge changes on IMR, but it looks nice when the when the change is so great. Okay. This dashboard is for demographics. Just your basic race and ethnicity, sexual orientation, gender identity, country of birth, preferred language. So as I said before, dashboards kind of give you more at a glance look. So this one, for some of the items, it just shows you the 5 most common answers. And then in the frequency table, you would be able to see how people answered to all of those different options that there are. But because there is not enough space on the dashboard to show everything, that's why for some of the items, we're just showing the 5 most common answers. Again, you have the data range here. Yeah, just basic demographics. This is another example of a dashboard. This is for one of the key indicators for housing. Again, it gives you like a little description here of what it is and some more information. And for housing, we split up all the items into 8 different levels, from level -1, which is basically for imprisoned individuals, all the way up to level 6, which is if somebody lives in their own apartment or housing. And it shows you a change over time again in each of those levels. You can see the previous assessment and the current assessment and how that's changed. This is another clinician rated outcomes. This is an example of a dashboard for goals. Again, you have a description here what those goals are, and you also describe them in more detail. But we have employment, housing, education, mental health, substance use, family reunification, social health, and physical health. And you can see the percentage of people who achieved the goal, made a lot of progress, a little progress. Oh, no progress. So there is a dashboard like that for each of the different assessments. So we have, just to kind of remind everybody, because I know that Andy already went over it, but we have clinician rated outcomes, which includes intake and discharge information, demographics, goals, milestones of recovery, and illness management and recovery scale. We have key indicators like housing, employment, critical events, and health. We also have client rated outcomes. It's a chance and also some satisfaction items from MISIP, and family and friends rated outcomes, which is the family and friends IMR. So each of those has its own dashboard. And now I just want to quickly show how the frequency tables look like. So as I said before, this shows you kind of like very detailed information about each of the items. So this is again an IMR example, and it shows you each item and how many people responded and the percentage. So each variable will have its own frequency table. And there's another set of frequency tables that also show change over time. So on the previous one, that will show you like everybody who responded to that assessment in the date range that you selected. And this set of frequency tables will only show you March 1st. So people who responded at both like the assessment that you chose from that date range and the previous assessment. And this is basically it for me. And now Edith will go in more detail about how to check if your organization is actually ready for implementing such a toolkit and kind of what are the steps to do that.
Thank you, Lucina. Okay, so I'll be talking more about the preparation phase. Now you've heard about the amazing features that this toolkit already includes, and there are a couple of things that need to go into the preparation, and we included a feasibility checklist into our toolkit and also data use agreement template. Now moving on to the feasibility checklist. So you might be thinking, well, how could my program now be implementing this toolkit? Or perhaps you work for a program or a county where you've already implemented some of the features that we're suggesting, but there are other parts of it. As we've heard, the toolkit is modular, so there's some parts that you could include to, even further your evaluation capabilities and provide even better services to your clients. Now, this tool, the feasibility checklist, helps you to assess your organization's current status and capabilities in terms of implementing such a system, but it also helps you to assess your organization's future capabilities in 1 year's time, once you've had a little bit of time to make some changes. Okay, so the purpose of the feasibility checklist is to encourage counties and programs to consider their organizational characteristics and also their resources in terms of implementing the toolkit or parts of the toolkit or any other data collection and reporting system. And the main focus really is to help you identify the obstacles. So what are the obstacles that prevent a successful implementation? Because that's really key here. And again, I just wanted to say another big thank you to our EAG who looked at an earlier draft of the feasibility checklist and gave some very useful feedback, which we've already incorporated into this draft. And I look forward to receiving more feedback this afternoon in a couple of the breakout sessions today. Okay, let's have a look at the feasibility checklist domains and also example items. So we have 5 different domains and 41 items in total on our feasibility checklist. The first one is the leadership domain. And one item that we would be scoring is, for example, county administration leadership prioritizes and values data collection for evaluation and quality improvement purposes, which is a really important item. Then we have staff resources, another important domain that's being scored on the feasibility checklist. One example item would be we have adequate staffing to oversee and manage the assessment completion process. Staff time. So staff has time to complete a 10 to 20 minute intake assessment for each client. Training, also very important for successful implementation. So our staff members have training or they have been trained or have time to review training materials about the importance of data collection, quality and completeness. And finally, the 5th dimension is technical requirements. For example, our staff members have routine access to data analysis reporting software, for example, Excel. Okay, let's have a quick look at the feasibility checklist. And this is the first page of the checklist. Now, at the top of the checklist, you can see the instructions. And these instructions are twofold. They let you assess your programs or your county's current situation in terms of implementing such a system or part of the system, but they also let you look at your county's or program's future situations in 1 year's time once you've had sufficient time to make some necessary changes. On the right-hand side, you can see the rating scale of the feasibility checklist, and it goes from 1 strongly disagree to 5 strongly agree. So there are the instructions, the score range, Then we go into the 5 different domains. So on the first page, you can see the leadership domain. You'd be assessing the current status and also the future status. And at the bottom of the page, you would be scoring the domain score, so the average score across the different scores, and higher scores mean a greater feasibility of being able to implement such a system. Now you can complete this on paper, or you could also complete it in Excel, and our toolkit already provides a tool for you where you can enter all of these scores into Excel, and it already gives you the average scores for each of the domains and also an overall score. Now, once you've gone through the checklist and you have your scores, the main part really is to interpret the scores. And again, we've provided you with some guidance on the score interpretation. So these scores really help you to identify the specific areas that need improvement. They also help you identify the areas your program or your county is really good at. So that's something really to celebrate. But really the main point is also to look at some of those areas that need improvement. So we've provided you with 5 different score ranges, as you can see on the screen, and also interpretations related to each of those score ranges. So if you find that your program might be scoring in the lower score range, that really means that there needs to be some major systemic changes before you implement such a system. But many of you, as we've seen, already have implemented a data collection system, and you might only want to implement parts of the system. Then you'd already be scoring in the green ranges, so only minor changes would need to be made. So once you've interpreted your score, really the next step is to develop a plan. And again, our toolkit provides you with a ready-made workbook that you can use with your team to go through. And on the left side, you can see the domain scores. So you identify the domain scores where your program didn't do so well or you didn't score so highly. Then you can identify the next steps. So what are the next steps that need to happen? And then you can also look at any potential barriers. And this is a really handy tool. So it's already ready-made, and you can use it for your team discussions or at county level discussions, really to look at the different options and how to successfully implement the system. So I look forward to receiving more feedback on this tool this afternoon. And just a very quick word about data use agreements. As you know, the assessments that Andy talked about, they all capture personally identifiable protected health information, or at least parts of them do. So it's really paramount that this information is stored securely and is managed securely and is also shared securely between organizations if you are sharing this type of information. And one of the benefits of the toolkit is that our toolkit already includes ready-made data use agreement templates, which facilitate the sharing between organizations. So you can carry out even larger evaluations or more comprehensive evaluations across organizations. And we recommend that this data use agreement is used for counties or programs that don't already have, obviously, data use agreements in place, but still, you should adhere to local protocols. Now, with this, we're moving on to the next section, the promotional materials. I'm handing over to Gina.
Thank you, Edith. Okay, as we wrap up this section of our afternoon, I get to talk about promotional materials. And I personally think one of the best promotional materials we have is the toolkit in and of itself. And we've already talked about some of the PDFs and some of the things that are there. But I also want to remind individuals that this is not a promotional material that you get to walk away with this afternoon. So please keep them on your table. This one says Gina's copy. So within the toolkit itself, we understand that a big part of implementing something like this is you'll go back excited And you now have the role of getting the individuals in your organization, your program, and your county as excited as you are. And so we are continuing to develop this section, and I look forward to the roundtable this afternoon, who will get to provide some information about what's needed and what kind of tools can we provide to help you get your county or program excited about this toolkit as well and get them on board. Some of the things we've already created are some announcements and flyers that will be in the toolkit. We also, in the email template that I'll be sharing, is already an attachment or in the appendix. And we'll also be providing some communication materials that highlight what the importance of the assessments are to the client, because this is a really important piece of making sure that the clients understand the information that they're filling out, how it's going to be used, and how it will benefit them. So just a few examples to share with you this afternoon. In the toolkit, we have an email template that you can use that announces the implementation of the toolkit and gives you some wording that lets you already have a nice pre-packaged email that, of course, you can change the wording and make useful for your individual county or program. But it already identifies what we think are the key features so that you can have the language already at your fingertips to be able to share with the individuals in your program or your county. We also are including some flyers that are, again, in a template format. So if you want to use them exactly like they are, all you would need to do is change the training dates, the location, and the information of who it's from. Of course, you'll be doing some training, and we've got a need for hearing back from you all this afternoon about what kind of training you see would be helpful, and if that looks individualized, if it's web-based. But whatever training you do have, this is a template you could use to let people know that a training will be happening. And then lastly, and this is probably my favorite, just skip right past it, probably my favorite part of the promotional materials that we have and the training materials is an example of wording that provides information to the client about the use of the integrated self-report or the integrated self-assessment. The reason why I like this is I can remember as a program manager that I would work with my clinicians, and if I got them on the same page as I am about having another form to fill out with a client, the following question I might get is that they were having difficulty doing so. And I found that it was helpful if there was something already scripted for them to be able to talk through with the client, because inevitably, and ours was a home visiting program, you get to the home and there's a dog there and a raccoon and a whole family and it's chaotic and you can't even remember if you brought a pen, let alone sell them on the fact that you need some additional information and that it's going to be valuable. And so to have something scripted gives your clinician sort of an ability to not have to think ahead about how they're going to share this client self-report, but it gives them some key language that's very true in the sense that the tools and the assessments that are in here are really great for clinical utility and the fact that it will guide the treatment planning. And so we've got a nice template here, and you could add to it things that are going to be useful for your program so that you have something scripted. So it's the front page of the assessment that can be read and gone through with the client first so that they understand what's happening, and also that they understand that they have the right to decline any of the questions that are being asked, but that they would know that the information will really help in their treatment planning and being able to reach those goals. It also helps the client identify some of the needs and think about those as they go through the assessment themselves and be able to pinpoint some of the needs that they may not have thought about or may have forgotten about. And so this is my favorite by far, and I think it's a wonderful tool that we're using. Like I said, this afternoon we'll have some opportunities for feedback on what training and promotional materials will be needed, and I look forward to hearing that. And so with that, I'm going to hand it back to Andy to get us organized for the next part, which is where we get to hear from you.
Thank you, Gina. So, I know we've talked a lot here today. That's it for us. Now, I'm going to spend the rest of the time here hearing from you guys. And so, I put together some possible questions for our discussion. Oh, and also, and I was going to ask now, could folks pass those cards, perhaps, if you have cards at your table, to someone at the table, and we're going to be coming around and picking those up. And so, it's really open discussion time now. Would love to get your comments. Please feel free to be critical. I would suggest. And of course, I know each county has its own requirements and things that are already required. And I would say that's not really something we're going to solve today in terms of attacking other requirements outside of things we're talking about today. But I want to make sure I just recognize I do understand that you have to look at this in the context of, oh, wait a minute, we already do these things. And so now we're thinking about adding something additional. And again, I'll repeat that. That's where we have to make sure that it has enough value for you to find the pieces where it is worth the effort. And so I'm just going to leave this. Hopefully people can read that, but it's not too important anyway. These are just some ideas of things you might want to consider in terms of discussion and comments. And again, feel free to be critical of how we could do better at this toolkit. And oh, we have folks here with microphones, so we'll go ahead and bring a microphone to you. So,
Hi, I'm Jen Terhorst from Nevada County, and I wanted to ask in regards to integrating data that's already being collected, DCR data, CSI data, misship data. Are we going to have to contact each of those agencies individually to get them to share our data with us? Or I know, or do we just pull raw data and follow the steps in your toolkit?
yes, both. So basically, certainly following the steps in our toolkit should set us up with any data source, but especially CSI would be an example where we are trying to give additional guidance and help so that because it's just such a common thing. So you saw the mapping for the data integration, that we're going to already do that for you for a few common things like CSI. And it's worth mentioning, while the forms have changed just a little bit, during the pilot, we already got something very close to these forms into Clinician's Gateway, Avatar, and some other places. I'm going to mention cards while we're going to our next person. I'll kind of go back and forth with some of our cards. That certainly the toolkit is going to be free for contractors. It's pretty much going to be free for everybody in a sense that unless HSOAC wanted to put any special restrictions on, there's really no restriction of why somebody from Sharp wouldn't have access to seeing where this toolkit is available and being able to use it for the greater good.
Hi, I have a question about the dashboards. Are you able to input information for specific programs and look at them individually, and then look at them collectively as the overall agency? So if I wanted to pull out just FSP information and then just pull out our outpatient information and then simultaneously look at it all together, is that going to be possible to flip through pretty quickly in the dashboards or identify who's in each program as we input information?
So yeah, each form is kind of a separate dashboard now, and so the clinician form and the client form are kind of their own dashboard report, and then through the data integration is where we could pull For example, you gave the people have mentioned DCR, so there were like the housing field from DCR theoretically could be pulled and put into here. I hope I'm getting at your question. Mm-hmm. Yes. Right now, the programs, and so yeah, this is the kind of feedback we need. Thank you. That right now, the program is itself, basically, it that yes, the report is kind of on everyone in the spreadsheet, and of course, we could be clever in terms of selecting certain subsets and such, but we want to help you out as much as possible to provide that ability. And definitely, those are great comments to tell us things that are missing that we still haven't put the end on the story for the toolkit.
I have a question with the DCR. So currently we fill out the CAT and the 3M and all the standard DCR forms. A lot of these things map to those fields. So does that mean that it would eliminate those forms, or is this now going to be an addition to those forms?
Yeah. So right now there are actually I know we have some of our MH data folks here in the room somewhere. I haven't had a chance to meet in person, but basically that we are not, I guess, redundantly creating a toolkit which where there is already the DCR toolkit where we can look at those fields, and so the thought is, and we'd like to keep on getting better at this part, that if you're using the DCR fields, that you might want to go ahead and look at the analysis of that in the DCR toolkit that was created. But certainly you can, using our mapping, you could pull from CATs to basically say, based on their most recent CAT, what is their housing situation at this time? But we don't have it built into the toolkit, as you can imagine, where we have all the CATs and it would magically know where to look for their situation. But then that's also great feedback in terms of adding to our wish list, because again, we're still thinking about what other final touches we might put on it.
I have one more quick question. Is there a way to put an identifiable number to each survey entry or to each assessment entry, meaning that I can look at client 111 and how they're trending over time?
So when you enter the data, each assessment is one line. So basically a person has multiple lines. So basically they have their baseline assessment as one line, then their 6 months later as a line, and it has their identifier and the time of the assessment, and then the dashboard basically looks into that long list, and then using rules that you define in terms of the time interval matches up the most recent within the time interval that you've selected to one that is earlier by an amount that you've selected.
Okay, can you pull out individual client IDs to look at over time? Like, I just want to look at these 5 people because they're in a specific program. Can I pull out those ones and see individual trending, or is it?
That's just like the other question in terms of right now. Certainly, you could look at just those 5 in its own sheet, but from the feedback we're getting here, we are considering how we could make an indicator. So you could say, okay, I want to mark these 5 and have them be the ones that are included in the report. And one of the things that was really great feedback from people, it wasn't, I guess, in the original plan, but we're still kind of, we were just planning, Lucin is our artist on these things, that we were just planning how to make a better individual level report. So basically something that the clinician used to say, I just want to see this person. How are they doing right now and compared to how they were 6 months ago? Yes, and 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 I will say that actually a lot of that the toolkit itself is a little limited in some of these ways that we're talking about. There was some limit to our resources, though MHS took care of us well in terms of to get what we needed to get this accomplished. But we did have to, again, there's some things that are on our wish list that we didn't quite get there, but that do exist in other systems and are implied within our document of with our statistical guidance, things such as this individual report where I already know some counties that do a very similar thing using their system certainly generate the individual level report.
Hi, I have a question in terms of if this information is being held within our EHR, are we supposed to extract from the EHR and place into the dashboard?
Yes.
And the dashboard is an Excel that generates the graphs. Is that kind of how it's working?
Exactly.
So then, sorry, so a way to get around this person's question is that if you're pulling from your EHR, you would just select those and pick what you want.
Thank you. And I think that's the answer to some of these questions is basically as long as you can select who you put into the spreadsheet and are willing to do that for your separate subpopulation, certainly you can break it up in any way you want.
Hi, I have actually 3 questions, but all related. So the first question is, who is the Excel guru who put the toolkit together, and can we call him or her directly for guidance? Perfect. Okay. And we can call you, right? Not sure. Okay. We'll table that. Table that for now. The second question related again to the Excel toolkit is, are the formulas and the VBA codes all exposed or are they locked down? Okay, so we can open it. Perfect. Right. And is it both VBA as well as formulas or just formula based? It's both. Okay, excellent. I forgot my
people to use it and that's one of the neat things about this that OAC is supplying in terms of we aren't going to be proprietary in any way over people saying, hey, we know how we want to use what you've created here to copy it to create use it for another form. And if you have folks who can basically play around with Excel in that way, we certainly welcome that.
Now, the third question is, when you pulled up one of the dashboards that listed the, getting better, not changing, and getting worse, is what type of statistical test were you running there? The reliable change index or something different? Okay. Great. Thank you. When you do that, can you call me? Thank you.
Other comments? I'm listening to these cards. If you gave us a card, but it hasn't been addressed, please do raise your hand. We'd love to hear it verbally. Several people have told, and we heard there's a lot of people here who are from FSPs. So I'll mention briefly how this is used by our FSPs. And I will admit, this may not be your choice in terms of still a little more resource intensive for the clinicians. But what our clinicians did in San Diego County and in a limited number of LA County programs that had to put stuff into the DCR is they, of course, didn't ask additional housing or employment, again, using our items. They depend on DCR for that. What they added was what is not in the DCR, which is the client reported measure. and the clinician, IMR, and more. So really just 16 items. And again, I admit that even 16 more items for folks who are doing the DCR is not ideal. And I'll point back to our earlier project that I talked about. That was one of the things that we kind of provided a framework for, but we aren't ready to drop the DCR yet in California. But basically, we did provide a framework for a system like this that would put together the DCR with these outcomes and eliminate the cat was our possible proposal. Mhm. And this one came up again, ages that we have said for adults here, and I know we have specific definitions of what adult means. Certainly, in this sense, we are talking generally designed for 18 and up, but totally appropriate for transitional age youth, 16 or 17 as well. So I would recommend the system for a transitional age youth program that served 16 to 25, but if it's surely a teen program or certainly younger, I'm going to say, well, let's look for that in a future toolkit. Yes, and so yes, I feel this is totally appropriate for them. And I'll add in our, because some folks may want to look back at this, so I'll mention it. In the toolkit, we packaged up the key central components, and we couldn't address all of our special populations. If you look back at our last deliverable for our earlier project, it clearly lays out for transitional age youth, add these additional education items. For older adults, add these specific physical health and mobility questions. And so we had a few, a handful of questions that were only specific for a certain population. Yes. Right now, it is in English and Spanish, and the self-assessment, as those who participate in the questionnaire group today will find in the breakout session, is still a little bit being finalized in some elements. But ideally, we would certainly recommend having it translated into all threshold languages for your county is usually what we do for most counties. And I think the answer, and of course the answer there, I'm going to get back to my sales pitch on why is it good for us all to use common things? Well, of course, things like translations. If we all use a different self-assessment, we're not going to build up that nice library of translations so that when a new county comes on board that may not have a whole lot of funding and a lot of diversity they need to serve, that they'll have a head start. And someone asked if there will be, they use the term soft copy of the toolkit. And if I get it right, I believe that certainly we do imagine this to be mostly an online sort of thing, even though it is a physical document. As you can see, you can hold it. I think it's going to be most effectively used as an electronic document, especially with its links and all those sorts of things. And good comment here that I'll just mention that certainly to make sure that in our training materials, we're paying attention to how people, once they have this dashboard, how they can best communicate it to stakeholders or people perhaps, and people without an evaluation or mathematical background to give them a little bit of guidance on that, which I think we're approaching in those upper blurbs, but something for us to pay attention to. We had a variety of counties who participated in the pilot, and And we did have small, medium, large, north, south, but we're still limited, of course, in terms of only a little over a half dozen counties. And so we realize there's that. I know I've heard from other folks. Oh, I think it's Mitra who said this quote. Um, that with 54 counties, if you've seen one county, you've seen one county. Was that you? Yeah. Any other comments? You guys have given us great feedback here. And so a couple people asked things about requirements, and I can't say much about that in terms of it's just going to be totally up to the county or program. And I will admit, someone may turn this into a requirement, as a couple counties that I've worked with have. But I think I believe they've made it a well thought out decision that involved county stakeholders and the contractors and other people who should have been in the conversation. But yes, once the decision was made at the county level, it was a requirement and it started to be put into the county contracts with their contractors. But to remind us all, as far as MHSOAC and the state is concerned, this is just a gift they'd like to give to you to help you in your work, and they are not right. They aren't associating it with any additional requirements. And it certainly does, as folks have been bringing up. I think it helps inform a future of where we will consolidate systems and such, and perhaps have more common ground between our different systems and how they work together.
So coming from a really small county, I think one of the biggest challenges that we face in terms of evaluation is that is in terms of collecting follow-up. And so getting on that 6-month or that 3-month program, and especially because our EHR at this point doesn't have some sort of flagging capability, and we likely wouldn't put most of these tools in our EHR anyway. So does the toolkit come with any sort of flagging reminder mechanism?
It doesn't right now, but certainly it's something for us to think more about in terms of what features we might be able to add, and keeping in mind what we would add in the future. And I will mention certainly, when you look back at our deliverable 5, our last deliverable from our earlier project, it pretty much clearly states exactly what you're saying. Whatever system you put this in, there should be, if possible at all, some sort of flagging, and that is how it works in some of the systems. Which, of course, I'm being careful today to not really support one system over another. All right. If there's no other comments, I believe we're at our break time. Thanks for those great comments and questions. And now we'll take a break until 2:45. And then we may shift people around a little bit for the breakouts, depending on how the seating turns out. And so now what we're going to do is we're going to have each of our, one of our table leaders, facilitators, go ahead and from each table, just tell us 2 or 3 things that you found especially interesting or important, things that folks talked about. And I know that's like so limiting that you guys, I heard the conversations taking place, and I was so impressed with how many great comments and feedback we were getting. And we're going to take advantage of all of it, which is why we made sure to have someone taking notes at each table. So we're going to make sure to process and use everything we've learned here today. But now we're just going to have Francis go around, and if each of the facilitators could just kind of keep themselves limited to a minute or two of some of the key things they found interesting, or again, things that their group really was passionate about. So start anywhere.
Hi, our table talked about training. So I think the big, and also the kind of the promotional materials. So I think the big takeaways for us were to really sell those projects, to, spend less time talking about the MHSOAC, as lovely as it is, and CSS, but really kind of talk about at the line and client level, what's the benefit of this project. We also felt that it was important to have pictures of cats doing funny things pretty much everywhere, to get people to look at the materials. We also felt in terms of training that it is important to have in-person trainings, at least at first, to have people connect with the topics, but then afterwards that people learn in different ways. So to have WebExes, to have you know manuals that you can print, things of that sort, and especially because most of us deal with kind of high levels of turnover, and so needing to train new folks and retrain people. I made a plug from the data geek side that we have some technical assistance in terms of benchmarking. So we saw the data, like the fake data of the improvements from the IMR, and it's like, what kind of improvements should we really be expecting to see from our program? What else did we? Any big high level takeaways? Okay, I think that's it.
So our table discussed the dashboard, so we looked through the data, the charts, the tables, and we had wonderful discussions. So in general, we felt like, the dashboard was pretty useful. It does provide us the information that is like one-time snapshot. But what would be more useful is if we can find out a way to track changes over time. When we look into any particular client groups or any particular program, instead of having this one-time snapshot, we would like to find a way to track any changes over time. So like, 6 months prior, and then current, 6 months after, 12 months after, so on and so forth, So that's one of the major points we have made during the discussion. And also just some technical stuff, So when we look at the pie chart and the bar chart, if there is a way to, or maybe that is possible or allowed on this the Toolkit website, but if there is a way to kind of for us to change the chart type, from pie to bar, and then add the print date, because data changes all the time, So if we can just, find out a way to, print out the date, that is associated with that particular chart, that would be even more useful. And what else? Let's see. And also we talked about ways to kind of assigning a unique identifier, which is, if we can find a way to kind of, this is particularly useful for data mapping, because when we look at this dashboard and sort of combine that with the DCR and some other types of program for data collection. So if we can find out a way to add a unique client identifier, that would be extremely useful. So anything else?
So our table did promotional materials. And Andy, we want to make you a star. One of the most popular suggestions at our table was that there be a short orientation video that could be used particularly with upper management to try and persuade them that the toolkit is a good idea, and or that might be used more broadly among managers or staff also to help them. That could be embedded in an email as a link, here you can watch this little video and tell us about it, so that it's not just written materials that people are receiving. And the other, I think, really big takeaway was that the CHAMPS language needs to be revised. That it is not perceived as recovery-oriented enough and client-centered enough. So we had some discussion about that.
Yeah, it's always great to have the input from people who are in the trenches doing the work to say, oh, you might want to think about that. And again, keeping in mind that the need to have materials that can be used with a broad variety of audiences. So sometimes, for example, on the questionnaire where it says clinician assessment, having that be provider assessment, because sometimes parts of that are being administered by someone who is not a clinician, but you give them something that's labeled clinician and they immediately go, whoa, I'm not qualified to do this. I'm not going to do this. So keeping that perspective in mind when preparing all the materials of the toolkit.
So we had a really good discussion about the feasibility checklist. There were great comments about a lot of the items, how we can make them more clear, rewording a few of the items. So we spent a lot of time on these. Also the rating scale, how that could be improved. So there were some very good ideas on that. In terms of the instructions, making it clear what we mean by the current assessment, but also by the assessment in 1 year's time, or the situation in 1 year's time, really making the instructions clear for everyone. A really good comment was about budget. That's currently not included in the feasibility checklist, and it really mirrors what we've had from our stakeholders in San Diego. So that's definitely something that we'll be looking into. We talked about how to develop the plan and how to make this an even more useful discussion guide, and also how we could use the Excel tool that we have to automatically populate some of these, some of our ratings.
Hello, we discussed the questionnaires, and the first assessment we looked at was the CHAMP, the integrated self-assessment, and everyone at the table felt like it was way too long, that it just wasn't feasible, to ask people 40 plus questions. However, there was concern about reducing the number of questions because then the assessment would lose its comprehensiveness. So we kind of went back and forth on that, but eventually agreed that it needed to be a shorter assessment. And then at the very end of our discussion, Andy comes over with an abbreviated version of that, or an alternative version that he can talk about. And we did prefer that version to the CHAMP, and there was a consensus on that. In terms of the illness management and recovery scale, we agreed with the stakeholders that it is useful and very necessary to include as part of the assessment package. The only concern was gaining access to family members and friends. How were we going to reach them? Because they wouldn't always come into the office. So my colleague here suggested that we have a way to mail that out to family members and friends, or some other way to reach them, of course with the client's permission on that. But we felt like that was very useful to include. Other than that, we liked the outcome measures. We felt like they were easy to complete and would fit into the staff workflow, since it's already being collected as part of the electronic medical records. We only had 2 people at the county who were represented at my table. Everyone else was OAC staff. So we were kind of limited in terms of the feedback that we received. But the 2 that were here said they thought that there was a high likelihood that these questionnaires would be adopted for use in a program. So very positive feedback.
Great to hear that excellent feedback. And the questionnaire I showed you guys towards the end was the result of our earlier regional meeting where we were already on responding to the concerns about that length. Right. Yep, so we got 2 items instead of a whole section. Thank you.
We also had some feedback at our table that having a more detailed assessment of substance use would be helpful. That's just from looking at IMR and the 2 items that are in the IMR. But we talked about dashboards actually, and we also got some great feedback and also some feedback that some people here are ready to or would like to implement it in their counties. The most kind of important feedback that we got, so one was to be able to sort clients by program and kind of look at the data from a more general, high level, and also more specific, by program level. It's kind of the same feedback that we got previously. Another thing is that it would be great to have some sort of a referral tracking system as a part of this toolkit as well, to kind of see where clients get referred, if they actually use those referrals, and then kind of what programs they actually end up using. And to do that, some of the suggestions were to create a blank kind of template so for each county could list the different programs that they have, or maybe categories of programs, and then to kind of be able to track clients that way as well, like what programs they end up using. And another piece of feedback that we got, it would be great to have ongoing support, technical support, and training. That would be an important element for counties to be able to implement it.
Great comments. Thank you so much. And thank you all for those great comments. I just can't thank you enough for how active and engaged the groups all seem to be, and how much I was overhearing just wonderful things in terms of what we could learn from and how to make the system better based on your feedback. And so as we wind down now here today, we're going to have one more round of if anybody wants to comments or questions. And so I'm actually going to go ahead and do that now. And then I just had a few final words of thanks. And I wanted to also let Fred say a few words thanking you all for being here today. And so did anybody have any other comments, kind of for our end of the day as we wind down? Those are, again, a few questions. We don't need to answer all those specifically. But if you had any comments about how we move forward here, or what your suggestions are for moving forward.
What their process has been, and lessons learned from those counties.
Yeah.
So that would be helpful, and maybe even a presentation at the mental health MHSA coordinators meeting through CBHDA may be helpful as well.
Yes, sounds like a great idea, and as I was saying, we actually did say a lot about that stuff in our final deliverable of our last project. Somewhat a lot of recommendations around that, and we were just talking about it in our Friday meeting last week that we're going to make sure that it's living in an easily accessible place, because there seemed to be a little bit of confusion among folks of telling us they had a cat, telling us that they found it on an online portal, but it's actually most people had to come to us to get it, and we haven't officially posted it on the OAC where we're going to. So there's no county that's implemented the toolkit exactly as is because there's this whole use it as you want sort of thing. But the toolkit, San Diego, with the pilot, when they participated in the pilot, implemented some of the pieces of this, and LA used it for used the very first pilot version for their innovations program. But we do have a scattering of other counties. Actually, we're really excited that Marin County is we're right now working with Clinicians Gateway and Marin County to put in some of this into their Clinicians Gateway. And of course, once a county puts forms into Clinicians Gateway, now we've got economies of scale when another county wants to add similar forms. And Riverside used during the pilot, used a variation of this that was in Avatar, and so we've already got some part of the forms in Avatar. That's great input. And Nevada County used it in a basically used a third party sort of system to that we built during the pilot to collect the data and report it. All right. And I know we got so many great comments during those discussions and such. I probably do feel like we've already addressed a decent bit of these questions here. And so I just really want to thank everybody for what for me has been a really great day. I've learned so much from folks here. And of course, it's felt really great that people have seen value in the potential of using this toolkit, while again, not giving us some great ways to increase the value and to make sure we're addressing the concerns that you brought up, which were just fantastic. And so our next steps for our part is we're going to take everything we've learned from you and from other regional meetings, get back with our evaluation advisory group and OAC partners, and we're going to revise the toolkit and then and revise these promotional materials based on the great feedback we got here today. And then we'll be working with OAC, not in years, in months here, to basically produce a released version that's ready for use by you folks here in the room. And so we would love to hear from you. Feel free to start contacting us if you just want to make sure you're that you're getting all the information and such that comes out. Of course, I expect there'll be some big announcement through CBHDA and mechanisms like that, but feel free to ask us to keep you posted. And thank you all so much for giving your time here today. I'm going to leave it to Fred to kind of finish us off here.
Yeah, just real briefly, I want to thank Andy and his team very much. A lot of work went into the toolkit in this day. Thank you. And thanks to the OAC staff who participated, specifically Kayla for all the work that she did in San Diego and here in Sacramento. And of course, thank you very much. Thanks to all who participated, especially you who stuck around and helped us in terms of working in the work group. So thank you very much.